We now have Dr. Parul, who will be talking to us about post-surgical corneal edema. Dr. Parul.
Uh, Thank you, Dr. Namrata ma'am, Dr. Ajanta Pharma, for giving me this opportunity. I will be talking about post-operative, basically post-cataract surgery corneal edema, how to recognize, prevent, and manage corneal decompensation after cataract surgery. So, in our cataract practice, we always see that there is some amount of mild to moderate corneal edema that sometimes occurs in our patients, which usually recovers within 1 to 2 weeks. So, we are not talking about that corneal edema. We are talking about the edema which is irreversible, which is not responding to our therapy. And that happens because you have caused a permanent damage to the corneal endothelial pump. So we need to look at this severe kind of a corneal edema and how to manage that edema in our practice. So we do see two types. The corneal edema can happen in the immediate post-operative period, which is an acute corneal edema, and when it develops later in the after cataract surgery, so after a few months, then it is a delayed or a long-term corneal edema. So, some of the reasons why we develop the acute or the immediate post-operative corneal edema. So, some of the patient risk factors being the deep set eyes, small eyes, hyperopic eyes, the eyes with short anterior chamber depth, so less than 2 millimeter of depth, or those eyes which have cornea with Fuchs dystrophy, Gutte's, or the posterior polymorphous dystrophy. And there are corneas which would have low endothelial count, which would succumb to the cataract surgery and give rise to corneal edema. Some of the intra-operative risk factors include the excess or the prolonged use of ultrasonic energy during the cataract surgery. So, especially when you have a hard brown or a matte cat, when there is a excessive ultrasound energy which is used, or a novice surgeon who's just learning the phacoemulsification, and there you are likely to have more of endothelial damage. Any increased manipulation of the instruments in the anterior chamber, or increased turbulence which causes the nuclear fragments to move around and touch the corneal endothelium, can also cause corneal edema. Intraocular lens, while implanting it, if it touches the corneal endothelium, is going to cause loss wherever the endothelium has been touched by the lens. If you have any complications like vitreous loss and vitreous is touching the corneal endothelium, you're likely to have corneal edema. And another reason is a dismissed detachment, which itself will give rise to a corneal edema if it is not taken care of. Some of the other common causes are TAS, which is already been discussed in the retinal session. Endophthalmitis with secondary corneal edema. There can be a reactivation of herpetic or a viral endothelitis or a keratouveitis in the post-operative period. Sometimes you can have a retained lens or a epinuclear fragment, which itself can cause corneal edema, which is not responding to your therapy in the post-operative period. So you have to look for those things when managing these cases of corneal edema. The long-term corneal edema, it is basically if you have a low endothelial cell count, or a patient has an associated Fuchs corneal dystrophy, or you had complicated cataract surgery. These are going to ultimately result into a corneal edema, which you will not respond to your medical line of therapy and would require a surgery eventually. If you have implanted a lens and if the lens is malpositioned, or the old types of lenses where they do cause UGH syndromes, these are predisposition to your corneal edema. So how do they present? They usually present with a painless visual loss, uh, or there is a non-improvement of the vision post cataract surgery. Presence of pain indicates either there is a infection or there is a raised intraocular pressure, so it should alarm the surgeon for the same. So the routine management, I think if you don't have excessive inflammation or pain, one should resort to their routine line of steroids, not increase the frequency of steroids. Add on to the topical hyperosmotic agents like hypertonic saline solutions and ointment. Unless the pressures are high, we should not be adding any anti-glaucoma medication, considering that the corneal edema would respond to your anti-glaucoma medications. In our current medical management, we have Rho kinase inhibitors. So, since you've had a recent endothelial injury, it is wise to add these as topical medications in the immediate post-op period because they would help in the faster and a better endothelial recovery. And we need to observe the resolution of the edema. So, ideally, it is best to wait for 3 months for the spontaneous resolution of corneal edema, and if it doesn't happen, then I think we should resort to a surgical line of management. So, how can we prevent it? So, it's a careful preoperative evaluation. So, a retro illumination or a direct illumination, you should be able to look at the corneal endothelium and its pathologies. What can help you is a specular microscopy. So, preoperatively, if the count is less or if you have gutties, then you have to take proper intraoperative care so that you do not damage the endothelium. So intraoperatively, so use the incision location. So if you have a deep set eye, go temporally. Use of dispersive viscoelastic, okay, less ultrasonic energy, or you can use a combination technique of torsional phaco. Prevent repeated entry and exit into the anterior chamber with your irrigation on. The controlled unfolding of the intraocular lens, especially when you're doing a wound assisted entry. And in the bag, placement of intraocular lens is important to prevent the future UGH syndrome. Descemet detachment, how do you identify in the post-op period? Is that when you look at the edema, which is in a patient with a DM detachment, you will see that there is a clear area and there is a well demarcated edematous area. So I think that should alarm you that there is a likelihood of a descemet detachment. You can use an OCT to identify the same. And do you always treat it? Not really. If you see the smaller detachments, peripheral detachments, and planar detachments, so if it is not very off from the corneal stroma, I think you can still observe these patients for 3 to 4 weeks and they would spontaneously resolve. But in cases where the detachment is higher, larger, in the extent involving the pupillary area and it is a bullous type, then I think one must use either air or C3F gas injection into the anterior chamber to deposit the Descemet's membrane. So this is just the video. I think if I so here actually here there was a small intrastromal bubble which had gone. So between the stroma and the no, Descemet's membrane. So you should avoid this kind of this thing. If you think that you are not in the right plane, and your bubble is not moving, it's best to stop and go into the anterior chamber. Your angle of the needle should be such that you are pointing towards the iris or towards the macula, so that you are not going to engage your Descemet's membrane. And once you identify that, you can probably do a vent incision and bubble, which is between the Descemet's membrane and the uh, uh, stroma. So TAS already has been discussed. So if you have developed a corneal edema because of it's just another 2 slides, um, uh, corneal edema. So you have to treat glaucoma along with corneal edema. Otherwise, the case really would not give a good outcome. And the last thing is surgically, you have to manage them. So DSEC, DMEC, or a full thickness surgery. So that depends upon the amount of scarring that you have in the cornea. If you don't have a scarring, you can go with a DSEC or a DMEC. And if you have a scarring, then you have to go ahead with full thickness surgery. Now you have to assess the intraocular lens. Sometimes when you see these cases, the IOL may not be a well positioned IOL. So you may have intraoperative surprises. So you have to have a standby your plan for the secondary IOL exchange during the surgery if you're doing a DSEC or a DMEC surgery. I think that's it. Thank you.
Thank you, Dr. Parul.
So I had a few comments. Ma'am,
Dr. Somshilak, if you can get ready for the talk.
excellent presentation and well covered. All the topics were very well covered. I'll go in a little different direction and talk about a little practical aspect of a patient, single patient with corneal edema, which you have operated and comes back to you. First thing is, do not forget about clinical signs. If it's going to be a patient of CAS, the patient is going to have intraocular inflammation. On slit lamp on high magnification, you have to look for cells and look for the glow. So if a patient is having TAS, they will have 3 or 4 plus cells. Then you suspect TAS more, and with the end of, you would not get a good glow and may have corneal edema with that. So do not forget the clinical signs. The second thing is an anterior segment OCT. If especially if it's your case, please do it. There's no harm in doing. If not available at your clinic, there are people who can come to your clinic and do it. You rule out a Descemet's membrane detachment, which may most likely require a surgical intervention. So ASOCT is a fantastic tool if you have a post-op corneal edema. The third thing is, when you use something like Ripasudil eye drops, you may get something like honeycomb corneal edema. So try to differentiate that between, edema due to an endothelial damage. You may want to stop Ripasudil at that time, because then you'll be just worrying that why my patient's edema is not improving. Switch to say another anti-glaucoma medication. So, in terms of corneal edema, these few clinical signs and small tests you can do to figure out what exactly is the cause in your patient.